All right, everybody. Dr. Rayford from Vet Triage. We are continuing through this issue of JAVMA from January 1st, 2016. It is a What is Your Neurologic Diagnosis? There it is. A 7-year-old. Oh, and this report comes out of the Mississippi State University Vet School. 7-year-old male neutered Manx cat, 3-day history, acute onset, severe non-ambulatory hind limb paraparesis and hyperpathia, dehydration, abdominal radiographs were normal. The referring vet treated with meloxicam and dexamethasone. Yikes, you don't combine those two drugs, folks. Non-steroidal anti-inflammatories like meloxicam do not get combined with steroids like dexamethasone. And they also gave isotonic fluids. The cat was moderately overweight, had increased respiratory effort, and a splayed hind limb posture. The neurologic examination found ataxia in the pelvic limbs. Now, here is already a problem. They had mentioned that the cat had paraparesis, which typically implies weakness and not ataxia. And so they mentioned in the neurologic examination ataxia in the pelvic limbs, but then they also mentioned slow hopping and slow proprioception, which again can both be slow when you talk about weakness or ataxia, but those things have to be differentiated based on your physical, and then they have a neuroanatomic diagnosis or neuroanatomic localization of L4 to S2, which implies weakness, not ataxia. That portion of the spinal cord, which is the cauda equina, so after L3, they don't have ataxia, they have weakness. So it's a bit inconsistent here with the terminology. That being said, it can be very difficult to differentiate between ataxia and weakness, especially in cats. And you could have a lesion that crosses the boundary of L3 to L4, and in which case you might get mixed signs, or you can have multifocal disease as opposed to what I was describing as diffuse disease, where you can have mixed signs as well. So just keep that in mind when you're going through your neurologic examination. And then the hyperesthesia was elicited from bilateral palpation of the quadriceps femoris, gastrocnemius, semitendinosus, and semimembranosus muscles. So sudden onset of non-progressive, non-ambulatory hind limb paraparesis with hyperpathia and bilaterally decreased patellar reflexes, which again is a sign of neuromuscular weakness and not central nervous system, and bilaterally absent withdrawal, flexor, and peroneal reflexes, puts a lesion at L4 to S2 spinal cord segments. Differentials include spinal neoplasia like lymphoma, aortic thromboembolic disease, myelitis, intervertebral disc extrusion. The complete blood count showed neutrophilia and lymphopenia, which is typically a stress leukogram. The biochemistry analysis elevated alanine aminotransferase and creatine kinase. So typically with the combination of those two, you're thinking muscle trauma and not necessarily liver. Thyroxine levels normal, anti-toxoplasma antibody suggested either recent exposure or infection. Urinalysis showed specific gravity of 1023, mild proteinuria, but urine culture is negative. Thoracic radiographs, enlarged cardiac silhouette, diffuse patchy alveolar disease, consistent with pulmonary edema, moderate pleural fissures, could be chylous, could be modified transudate, with congestive heart failure as well. Echocardiogram showed bilateral atrial enlargement, asymmetric left ventricular free wall thickening, all that to diagnose hypertrophic cardiomyopathy or HCM. Abdominal radiographs found isoechoic renal cortices, which could be normal renal tubular fat, or nephropathy or chronic renal disease. Thoracolumbar spinal radiographs showed multiple small ovoid to linear irregular mineral opacities in the intervertebral disc spaces from L4 to L7, and narrowing of L4, L5, and L5, L6 of the intervertebral disc spaces. That tells you that this cat has intervertebral disc disease. Differential diagnoses includes now thromboembolic disease or acute disc extrusion. So the MRI that you're seeing here in A, this is a ventrodorsal, all of these are ventrodorsal plane MRI images. A is showing that the aorta vascular supply is normal, meaning there's no thromboembolic disease. And then in B, you have heterogeneous, so right here, heterogeneous, but predominantly hyperintense, fusiform shaped, right-sided extradural lesion at L5, L6 intervertebral disc space, which indicates either subacute hemorrhage or mineral material. And then for C of the cauda equina, again, you notice that there's myelitis, hyperintensity of the cauda equina. And then there's these other images here, which are going to confirm the same thing. These are sagittal MRI images of the same cat. And so what you're seeing there is in A, you're seeing loss of dorsal subarachnoid space from L3 to S1 and mild hydromyelia. So that usually indicates a compression of the cauda equina in that area. Then hydromyelia indicates some chronicity to the disruption of cerebrospinal fluid. In B, in the second picture, there's a central hyperintensity consistent with edema, disc material, and hemorrhage. In C, protein-rich fluid, hemorrhage like methemoglobin or mineral material. And then in D, hemorrhage or calcified nucleus. Pleural fluid samples showed a modified transit date with no evidence of cancer or infection. The lesion caused severe extradural compression of the caudalmost portion of the spinal cord and cauda equina with leftward displacement and avid strong enhancement of the neuronal parenchyma that spanned L4 to S1. So acute extradural Hansen type 1 intervertebral disc disease with hemorrhage from ventral vertebral sinus rupture or extruded material of the nucleus propulsus was most likely, with secondary severe compression myelopathy with myelitis, L3 to S1, attenuation of the subarachnoid space from L3 to L7, and hydromyelia at the level of L3. So the cat went to surgery, L5-6 right-sided hemilaminectomy, which confirmed right-sided compression of the cauda equina. Large dark red gelatinous material mixed with white gelatinous material was removed and submitted for a histopath. Unfortunately, the cat underwent cardiopulmonary arrest and passed away. The histologic examination of the material removed showed degenerative fibrocartilaginous material, neutrophils, macrophages, consistent with the degenerative nucleus propulsus and hemorrhage. Comments. Cats with clinical intervertebral disc disease are middle age and either gender. They could be acute or chronic. You see narrowing of the intervertebral disc space and mineralization of the intervertebral discs. C6, 7, and L4, L5 are the most common intervertebral disc spaces. Acute hemorrhage can be seen, and in dogs with spinal extradural hematoma associated with intervertebral disc disease, hemorrhagic myelomalacia, traumatic intramedullary spinal cord hemorrhage, ischemic myelopathy, acute non-compressive extrusions, or necrotizing myelopathy are all possible. The elevated serum creatine kinase is common in sick cats and can be due to cardiomyopathy, bacterial, viral, or protozoal infections, trauma, arterial thromboembolism, renal disease. The alanine aminotransferase increase can be from enzyme leakage, ischemic muscle damage, iliopsoas muscle trauma from being splayed in the hind limbs, and non-ambulatory status. So yeah, I mean, it's a pretty thorough case. They mentioned a bunch of details regarding the MRI, which I kind of glossed over without actual imaging to show you. It doesn't really matter much, but pretty typical of what you'd see with a severe acute intervertebral disc disease. And I don't think this was entirely acute. I think this was acute on chronic because there were clearly changes of chronicity here that I wish they mentioned more, with mineralization of the disc spaces, narrowing of the disc spaces, hydromyelia. But anyway, unfortunate case, but for veterinarians and for pet owners, do not rule out disc herniation in cats, even though it's more common in dogs. But they can. You would have thought in this case, this cat had aortic thromboembolism because he had heart disease and heart failure, and so kudos to them for pursuing MRI, because most veterinarians probably would have stopped there and said, he's got heart failure and this neurologic status in the pelvic limbs. It's probably aortic thromboembolism, which would not be treated with surgery. That'd be treated medically with a poor prognosis, whereas disc disease needs surgery and also has a fairly decent prognosis depending on their neurologic status. So, all right, we'll see you guys in the next one. Thanks.